Thank you everyone for joining the COVID-19 paradigm shift at Mayo Clinic, transitioning from tried and true to new and nimble with Dr. Joel Gordon. We will be recording this event and making this available to all of our Minnesota HIMSS members. If you would like to be a speaker or sponsor for a future webinar event, please reach out to us via our webpage, mn.himsschapter.org. Today's webinar is good for one continuing education contact hour. We will do a Q&A at the end of the event. If you have any questions that you would like answered, please type those in the questions section of GoToWebinar, and we will review those at the end of the presentation. I am pleased to introduce Dr. Gordon, a family medicine physician that serves as the Chief Medical Information Officer of the Mayo Clinic Community Practices. He is the Enterprise Chair for Usability and served as the co-chair of the EPIC Implementation Documentation Subcommittee. In 2016, he received his board certification in Physician Informatics and is a proud graduate of the EPIC Builder program. His interest in training end users has resulted in many novel learning systems, including the classes resulting in a brisk adoption of the virtual video visits as a result of the COVID-19 altered visit requirements. Through his involvement as an advisor to the knowledge management team, Dr. Gordon facilitated knowledge transfer of Mayo Clinic's COVID-19 expertise in the form of an evidence-based knowledge navigator to the international healthcare industry. This was accomplished through the EPIC social community as well as non-EPIC social networking. Dr. Gordon guided his local clinician teams to form the first Mayo Clinic drive-through community screening team, identifying the earliest COVID-19 infections in Greater Minnesota. This early identification of infections allows these patients to be tracked, monitored, and volunteer as the first patients in Mayo Clinic's plasma exchange bridge therapy trial, seeking passive antibody protection for future patients. Thank you, Dr. Gordon, for presenting today.
Thanks, Rebecca, and welcome everyone to the webinar about change management and the changes that Mayo Clinic went through. I also want to thank Minnesota HIMSS for giving me this opportunity to speak, and frankly, that introduction was enough to make me sweat, frankly. Simple country doctor in Mankato is probably better fit for my introduction, but nonetheless, this has been a super exciting time and a super learning time for all of our organizations in healthcare. And when I was first approached to do a webinar, there was a lot of different options in COVID-19, and I started kind of pursuing different leads on specific topics. And what became very clear to me is that there's been a shift in change management that occurred in our organization. And in our conversation today, I'm going to talk about some specific changes, both giving large and small examples. And then I'm going to pull us up to like the 30,000 foot approach and kind of talk about how these ubiquitous changes actually result in an alteration in culture, on operational and personal changes and those sorts of things. And I know that Mayo Clinic obviously didn't go through this in isolation. This is a worldwide change that's happened, and at the end of today, or end of this conversation, there's going to be time for Rebecca to open up the lines and take in questions through the chat feature, and I'm quite certain that there are things that we can learn from each other, like obviously I'm presenting, but I'd like to hear if you see things that your organization maybe did differently, and maybe where I talk about change management and where you felt your organization shined, and perhaps some of the sharing we'll all learn together. Now, nothing of these changes, interestingly, that I went through are unique or uncontemplated previously. All these changes were things that were on our plate and multi priorities and those sorts of things. Nothing here was necessarily Mayo Clinic specific again, so you might see similar patterns in your organizations, but I'm gonna go ahead and get started. So when I took on this conversation, I realized my singular perspective was just not enough. So I thought of an A list of change champions across our organization, and I approached them, and all of them were very gracious to give me their time. And so I've interviewed people from many different perspectives, whether they're leaders and presidents, or they worked in IT or knowledge management, or they're end users, that sort of thing. But all of these people had major contributions: Dr. Stout and Hebel and Gray, as well as Michael Ryan, Rose Anderson, Michelle Hoover, Sharon Kirby, who I believe is the secretary of HIMSS in Minnesota, and Nick Gajrawala. So I wanted to thank those folks if they're on the line. The learning objectives, first of all, I want to disclose that I have no financial disclosures to submit, and nothing here is really off-label. But I want to describe that as I looked at this, I kind of want to remind us about the two arms of change management. You have the technical change that you go through, the specific things that you're changing, the programs, the workflows, and that sort of thing. But you also have human changes, changes in behavior, changes in understanding, and changes of emotions about projects. And the next, that these two arms are intertwined in that if you change one, like obviously the briskness of our technical changes are obviously going to affect the processes and opportunities we find when we're managing the human changes that occur. And during times of heightened chaos, such as this pandemic, there are tools actually that you can have in your toolbox to optimize the organizational effects and improve communication, data acquisition, knowledge retrieval, administrative processes, and clinical functions. And I'll kind of go through those as singular examples as I go through those projects that changed. And then likely just kind of reiterate that organizational change management is just really an amalgam of multiple different personal changes that each personal change is experienced in that organization. And with these tools and investments, we can make sure that those technical changes can stay on as brisk and on time. So first, to talk about how we are now today, I'd like to kind of give a quick perspective of change management at Mayo Clinic historically. There's two parts of it, the technical and human factors changes that I've talked about before. In the technical changes, you kind of look at those in design, develop, and delivery. And in the upper left picture, I show kind of a very iterative change control process workflow that we've been slowly developing, where a change is identified, and then we kind of work through the processes to make sure it's moved safely, briskly, but actually almost perfectly, hopefully, through the system. And then governance is required, and on the upper right panel, I kind of give a very, very simplistic view of Mayo Clinic governance. What I don't want is someone to leave this talk saying, well, Mayo Clinic is skillfully doing what it's doing because of its simple and straightforward org structure. And that is just not true. It's a hyper matrix organization, and truly it would look like a spider web if I drew it up there. And so I kind of jokingly say it's like Einstein's special relativity theories, in which you have a cone of future light and a past light cone, and they converge on the observer in time, and they have a space and time continuum of which are the X and Y components. I know that these theories of relativity are accurate and powerful, but I can't describe them. And similar, our org structure is powerful and accurate, but I really couldn't describe it to you. But it is part of that designing a project, developing the tool to complete that task, and then the appropriate delivery. So that's the technical piece. The human factors piece, we utilize ProSci change management philosophies on that with the ADKAR that everyone is probably aware of, but it's awareness, desire, knowledge, ability, and reinforcement. And so in that together, the leadership and good, strong leadership and sponsorship can work with good project management keeping the project on time and on budget. But that change management piece is important to make sure that the change is successful. And that bottom right picture here, this one here shows us that we have change agents, and we have early adopters, and we have teams that work together to further the success of a project. And if you look at the relationship between change management and project objective success, it's very clear that we have a relationship between those, and a strong relationship it is. So I won't go further on that basis, because as I think of my personal life, I have the landmark dates: date of my marriage, the date of my children that were born, but I also have landmark dates professionally. December 30th, 2017 was the date that I hung up the forceps and stopped delivering babies as a family practitioner. March 12th, 2020 at 9:03 a.m. was another landmark day for me. So I'll back up the day before, and I get an email saying, hey, I need help to set up drive-by testing. Any ideas appreciated? And it's a nicely crafted email, and I looked through it and considered it, and they talk about, do we need, like, how many tables and chairs, and what about signage and traffic control? Do we need electricity to keep the refrigerators cool, and what kind of supplies would we need, and those sorts of things. And I finished up my clinic that day at about 6 p.m. and read through this important email. I was like, well, this does sound important. Let's meet at 9 a.m. tomorrow morning. Send off my email at 6 that night. Come tomorrow morning on March 12th, we sit down at 9 a.m. We get around our table and start discussing this, and knock, knock, knock on the door. At 9:03, one of our front desk staff kind of pokes her head in and says, sorry to interrupt this important meeting. There are people driving up, and they're asking to be tested for something. And we started having lineup of cars, and that's when it dawned on me at 9:03 a.m. on March 12th, there is a whole new paradigm going on here. So we have a paradigm shift that happened in our organization, and I think happened basically across the planet, is that we have at Mayo Clinic, we have this 150-year-old entrenched and tried and true change management system, and now we've altered, and we become this new, don't let perfect be the enemy of good, novel and nimble way of introducing change into our practice. So these are the 5 specific things I'll talk about. I'll talk about changing our clinical practice. I'll talk about changing the IT, and that was really through a Herculean effort for sure. I'll talk about changing research and how we represent data, and how we utilize the representation in maybe a more user positive experience, and then also storage of that and retrieval of that data. And then we'll change the communication channels, and I think that was really specifically palpable for me. And then the last one was with changing the academics, or more the knowledge content, and the curation of that and delivery of that knowledge content about disease states, but specifically about COVID-19. And again, I'll reemphasize that none of the stuff that I'm going to talk about is something that we didn't think of before. It's stuff that was sitting there, things that we were contemplating, things that we were considering to doing, but it changed in March, and that these things became immediately important. And so the summary of this will be changing everything, and including what did we do to manage that change. So changing the clinical practice for a pandemic. Well, there's in Mayo Clinic, when you say the clinical practice, that means a lot of things. I mean, Mayo Clinic's clinical practice, it could be focusing on local needs and regional needs, national needs, international needs. And we often are trying to balance those things. And sometimes it's, frankly, the same person wearing different hats, or same group of people that are looking from various perspectives. You'll see in the bottom left picture that this is our project Big Top, as they called it. The building, and the big, beautiful building in the background is where we do our clinical work. And suddenly that had changed, and we, like most organizations, started doing drive-through testing in order to decrease the exposure and consumption of resources like PPE. And so that was where we built that up on March 11th. But then we realized, as you'll see through this discussion, that this is kind of a Big Top is kind of a temporary thing, like a circus moving from town to town. This doesn't seem like COVID is moving from town to town. This may be here for a while. And so this, you can see Project Big Top, I guess, doesn't have a name now, but maybe call it Project Chicken Coop, where we now are going to be more of a structure that we drive through, and those sorts of things. So that was meeting that screening strategy for the local needs. And then the regional needs is creating community connections. How do we get that community connection? Well, sometimes it's kind of like indirect communications, like on our website, and having our leaders give distinct messaging about what's going on, and then specific information, instructions as people start to engage with us. What type of visits can we do, and how do we do those visits? And when we start to change how we do those visits, how do we get instructions to them? On a national need, it's really important that we influence and help decide state and maybe even national response systems and those sorts of things, and adding to predictive analytics as we can. And then international needs, and that's where I was excited to have my patients participate, was in this development of screening tests and testing tools and some novel treatment programs. So as we were kind of early on finding some positives and people that had traveled internationally in our communities, we were able to kind of direct them over towards the passive immunity treatment protocols to see if we can identify new and novel ways of treating this disease. One of the parts of the local and regional responsibility was to reach out to the community, because this, again, isn't a Mayo thing, and it's not even a healthcare thing. This is a community, this is a healthcare crisis that actually is really more of a societal crisis, and it's experienced specifically at the community level. So it seemed to be an obligation to help guide our communities through what COVID-19 meant. Dr. Jim Hebel in Southwest Minnesota did a terrific job of doing that, where he's reaching out maybe to the Chamber of Commerce and business associations, and each campus, each region had someone leading these sorts of efforts and giving a specific handoff in education about those communities, and specifically even in focusing on, maybe we noticed that the schools and higher educations in like University of Minnesota, and Minnesota State University, and the local colleges like Gustavus and those sorts of things, and University of Wisconsin-La Crosse had specific needs regarding this. But let's look at that timeline. In December, when Wuhan was identified as an outbreak, and then February, Mayo announces their preparedness, and then March we have that first case up in the Twin Cities, where Minnesota now has COVID-19 in it. And then 10 days later, Mayo is starting to restrict its travel and large gathering. The very next day, we released that PCR test, and those testing centers start that I told you about. Very next day, the first positive patient crosses through the thresholds of those test centers. And just a couple more days later, the first COVID death in Minnesota, which prompts us to really look as an organization about what we're doing. And we paused our elective outpatient visits and surgeries. So anything non-emergent became paused. And then virtual visits followed shortly behind there with Governor Walz giving his stay-at-home order. And just 3 days later, we're implementing our staff masking and serology testing development. So you can see this is quickly progressing, not over months, not even over weeks, but there's days between these points. And Dr. Hebel goes on to use the Minnesota Department of Health information showing these acceleration in outbreak that's happening, but luckily and thankfully, the hospitalizations and cumulative ICU admissions maybe are increasing, but if you look at them on a daily basis, they are plateauing because of the important and strong efforts we're doing as social isolation. So at that point, we're realizing that the COVID-19 testing, if we can do that on site and decrease the turnaround time, that can be a major advancement for the regions and reduce our PPE use and actually start to give results to the patients, so that maybe we can start welcoming patients back. And so we're seeing that this is COVID-19 models that we were working before. We were really concerned looking into Seattle and New York and Italy about this massive surge and consumption of critical care resources, that instead this is looking like an extended plateau, and that we have actually readied ourselves with adequate amount of PPE and PrEP. And so that we maybe even have some treatment modalities that are on the horizon. And so we're going to welcome patients back, but we're going to talk about a 5-point plan. And going through those, I won't speak of them individually, but robust screening, universal masking, and it's not an exception. And Dr. Hebel talked about one of the harder things that he had to deal with was talking about firm rules. And I didn't know what he meant by that, but he was talking about, when two parents bring a child to a well child check, one has to wait in the car. We're just not going to bend and let two people come with that child for the well child check. And how masking in the break rooms. Yeah, you're out of break room, but you need to be wearing your mask. And it's kind of a universal thing that we really adopted. And social distancing, making sure we have the wait here signs throughout our organization, and enhanced cleaning procedures and restricted visitor policy. So all those things, once you have all those, you've got those 5 plans to reopen, we can move forward. And why we presented that to the community is those are the same 5 expectations or points that we would hope we could convey to our area businesses to help them make strong and steady plans to go forward. And then the last thing on this slide is to talk about kind of a media blitz. We made sure that we did a local and strong media effort into every one of the 70 clinics that's across the Midwest, that each community had participated in basically kind of an infomercial. And it wasn't us talking to them, but the community members and leaders talking to each other in these poignant presentations that were across the internet, Facebook, and those sorts of things. So I need to move on to the IT changes. That's the second topic of changes. And changes in the IT are, and technology were really the vehicle to overcome the challenge beyond any other prior event. And so we were utilizing artificial intelligence to pattern recognize things about the viral replication, or maybe patient deterioration, or the community impact and financial impact, and those sorts of things. But it has significant downstream IT dependencies about bandwidth and utilization of storages and that sort of thing. We also had a big IT change in just hardware. We had 60,000 employees in 5 states and 3 time zones, and a third of those people had to be transitioned from work to home in 6 days. 20,000 people in a matter of 5 to 6 days reworked how they work. And then, of course, just like you folks, we had to kind of do that clinical workflow revamping it, kind of the home-to-home virtual visits, and adopted what I thought was important to kind of point out, that peer-to-peer follow-up training. And what that talks about is that in change management, frequently you need to have a change agent. Change champion. And so that's kind of the first thing that I'll mention, is that in this change champion, we had kind of different, we had peers that would step forward and kind of guide others on how to do this. And we kind of use this tool in different campuses at different times, but you can see that they, in a matter of 2 to 4 weeks, we're seeing kind of a variance between those organizations that started early with the change champion versus others, and that gave us 10 to 15% more access to the patients that need us, as well as 10 to 15% more visits that would help to contribute to the reason we're here. And this is talking about remember I said the IT movement to external. Each of these are unique badge reads each day, and you can see that there was a dip here where people were working more from home and that sort of thing. And I just wanted to point out that it wasn't noticed. The larger the campus, the more significant that loss was. And maybe in these smaller campuses, like this is Florida and this is in La Crosse, we're closer maybe to critical work staff on every working day. So it wasn't quite such a tremendous, it wasn't equally manifested across our organization about that change. And then other things, like this is a project that's remote patient monitoring that's been going on for months to years, and it's been working with 300 to 400 remote monitoring episodes each day. But then when the COVID comes in, you can see we're suddenly doubling as we amplify our adoption and utilization of different projects that became powerful and important pieces of the puzzle to solve this issue. And then artificial intelligence, just again with modeling, and there's many different types of modeling. Sometimes they were novel to what we were doing, but sometimes they were just composite modeling, using what University of Minnesota was working on and utilizing what other organizations were working on. So then changing data representation and storage, that's the third thing that I was going to talk about, is that the cognitive capacity for end users is finite. And so when you start to burden them with more and more quick speed of change, there's things that you can do to decrease the cognitive burden and improve capacity, like iconography, meaning using icons that give a lot of meaning, but you make sure that they're seamless throughout the organization, so those same icons mean something, so that in a fraction of time you can convey a lot of information. And then navigators, things that allow you to use processes, match your workflows to your informatics processes. And then usability heuristics never go away, particularly when you're going fast. And then I always kind of point out that good organizations are figuring out the best practices to get information in the EHR, but the great organizations are those that move on and figure out the best way and most successful way to get the information out of the EHR, formulating our decisions, guiding our care, giving us good and robust reports. And the EHR is only one part of the whole collective knowledge base which runs Mayo Clinic. And so we had to have something we were considering, we had to become a reality, and that was using a data intelligence tool, and that was launched here recently. So first, let me talk about the interaction and usability and that sort of thing. You see this is just a screenshot of my schedule. I don't remember what day exactly, but nonetheless, you can see that we have a COVID-19 scoring system, and it's not a risk score because this isn't validated or that sort of thing. But I know that COVID-19 isn't going to be equally manifested throughout the population. There are going to be people that have more and people that have less issues, and it's based on comorbidities. And so you can see this patient with 7 different comorbidities is going to have a higher risk. And then I need to know what does the lab show me? Positives and negatives are important with that PCR testing and pending and that sort of thing. And what about antibody testing? I want to have that visible to me, like the antibodies are present, condoning, not confirming, possible prior infection, where they're absent here, which are part of that. And then we have screening tools that we use at the door that let us know if they've been around a contact with person or do they have symptomatology that are consistent with it. And we've put those not just in one place, but those are on our schedules and inside the patient charts and on our track boards and snap boards and on our headers and dashboards and on our reports, so that they condone the same information going throughout. And then this is just how we embedded the navigator for the pandemic right into the usual workflows for the ED. Okay, and then nursing has their roles that they do, and the provider have their roles, again, kind of working top to bottom to work towards the discharge, the admit, and the clinical decision. The other part of data that we have is the reports, and you can see here, if I just search in our report library inside Epic, I have all of these reports, and this is, how many reports were generated about COVID. This is the fraction that I see here. So really, there's 12 different scrolls on this, so that's like 120, 130 reports were developed in a matter of just weeks. Okay, so the data is coming at us fast and furious. So we've developed kind of a mnemonic naming system, so that for providers, typically they want information about my patients, my hypertensive patients, my COVID patients. So if I just search on my COVID, I get down to these 2. It eliminates 128 other reports, and I get down to these 2. The all providers, meaning any patient that I touched, whether I'm a primary care provider or these primary care providers, like what patients are in my panel. And I can see information, have they been tested, and were they tested negative or were they tested positive, and when was that test, and was there follow-up testing, and were they admitted, and that sort of thing. So I can see and hear when I've interacted with patients what happened with them over time. And then with all of this information that's blossoming, data governance is extremely important. And so we utilizing a data intelligence system to accelerate not just any outcome, but trusted and good outcomes. So we connect the right data, the right insights, and get the algorithms and people. And you can see here, just even a data governance organization that's always been there, but let's get that up at front and center so everyone that's looking at data knows how to interpret and confirm. The next big topic was communication channels, and I could have done a whole topic on this one, but basically flattening because of the infodemic. We have many, many, many people with lots and lots to say, but in our intra-organizational communications, we needed to be more direct, have more universal communication streams, and things like video messages became very, very common. And directed messages where one supervisor would give to a sub-supervisor the message, and that would be, kind of given direct messaging to transfer from person to person, not everyone creating their own content. And then town halls were very, very frequent, where even Dr. Ferrugia here is getting together and taking questions just from the general audience, and those are happening on a very, very frequent basis. And we needed to decrease and pause non-essential communications, so those fell off as we really focused on the project at hand. But extra organizational communications were important too. And this is the intra-organizational communication that I was telling you about. Firmness but flexibility and honest humbleness had to be a part of that, because, for instance, Dr. Shoutout talked about, she was one of the things that gave her the most heartburn is that she was often giving messages, but then later contradicting herself, because what was true one day was false the next day. Like, what were the masking messages and that sort of thing. And so that's where the humble honesty and just telling people that I don't know if you don't know, and that sort of thing, served our leaders well. And then in financial, at like 3-4 weeks into this, we're looking at, this is the number of patient encounters, like clinical encounters that through Mayo Clinic, such as, Christmas break and that sort of thing. But this wasn't Christmas break lasting a week. This was weeks upon weeks, and we had some concerns, like, is it going to flatten out? Is it going to just snap right back where it was, A, B, or C? What's going to happen? Now I'll jump to the answer on that. As we look forward, we see it somewhere between A and B, but there's definitely a rebound of our patient volumes and such. But because when we were making those decisions, furloughs and salary cuts and these hard decisions had to be made with a lot of grace. And then external communications, we really rev those up either through the portal or direct through the emails, showing a significant volume of information. The passive information I talked about, posting on the websites, but this is active communication through emails and internet and portal to let patients know what's going on with COVID at their local healthcare and how do they interact with us. The last topic before I start to talk about kind of the culmination of all this change was changing our knowledge library and curation. So Ask Mayo Expert is an indexable and searchable knowledge content library, which is inside Mayo Clinic, and all of our Mayo Clinic providers and those that are associated with us through the Mayo Care Network can get best information, get best practices and care process models of which to guide them through whatever disease state they're thinking through, whether it's hydrocephalus or perhaps polymyalgia or rheumatica. What are the tests that I should do? What are the names of those tests? When should I do them? What is the treatment that's available? What experts are available for consult? Those sorts of things are in Ask Mayo Expert. Now, I don't know if he's on the line, but Dr. Steve Campbell was out in Seattle and gave me and some of my informatics leaders some of his time, and that's when I was doing the interviews with other leaders. I noticed that everyone was connecting with everyone. Everyone commented about either people in New York or people in the Pacific Northwest that were so generous with their time and so generous with what their experiences were, that were helping us figure out what we were doing, that leaders at Mayo Clinic felt was entirely necessary to and inspired to direct our knowledge content back and outward, not maintaining it just in Mayo Clinic. So with the Google partnership and the platform, that information was externalized. And that was the first time that Mayo had done that, where they'd taken this expertise and made it available for anyone. And then through Epic, our software vendor, we were able to create content links, so that other organizations, whether they're a Mayo Clinic or not, could embed this knowledge right into the software build at a foundation level. And we shared this information freely through the Epic user web, as well as other social media influence. We looked for Mayo Clinic providers that had a good, strong Facebook presence, and they were able to kind of mention this and get it out there, and other providers that had LinkedIn or Twitter presence. Again, social media influencers. I'm not sure if you can call people like me, a 50-year-old provider, as a social media influencer. I barely know what that word is. But that being said, we're utilizing these sorts of things. And this is the Covid19 Navigator that was put out, and it was universally available now, and where you can pick your venue, and then go to the common questions or discussion topics and drill down to the specific information you're looking to. Fairly useful. But this gives me pause to mention the other thing that was pretty ubiquitous when I was doing my interviews with leaders, is getting back to that don't let perfect get in the way of good, is that we put this out there and now it's out there. Now we're going back and doing our usability investigations to improve it, to make it right, to make it even better. And that just tells you that happened again and again and again, where we had to go quickly, we had to go swiftly, and we maybe even had to turn a blind eye sometimes to certain things about policy and those sorts of things. And I'm not revealing probably something that wouldn't be happening in other organizations as well. So we had to change the change system without wearing out the change agents. And I'm going to discuss how we change back to normal. But Michelle Hoover is in MENC, and she was one of the persons I interviewed. Management, Engineering, and Consulting is what MENC stands for. But Michelle told me how this, and basically what I wanted to ask her and have a big conversation about, was this a reaction to awkward external environment, or were these more data-driven and proactive changes that we went through? Because I could understand ADCAR and I could understand that traditional change management, but none of that applied. And so she thought about it a long time, and then she said, you know what, there's such a thing called situational change management. And really, I mean, she compared it it was in a hilarious conversation that made me laugh. She was kind of describing how do you escort someone after the movie's over is different than how you escort someone when the movie theater is on fire. And so that was funny, but it didn't resonate with me as much as after the fact. I kind of thought about it. Traditional change management for a clinician is like the traditional clinic work when I come into work 99% of the days. But situational change management occurs in my clinic when there's a code blue. Okay, first step, someone declares the code. Okay, there's zero ambiguity on the priority when there's a code. Everyone's nose is turned to the one issue that's in that clinic. And you assemble a code team, okay? And when you assemble your code team, you determine roles. There's a single leader. We don't have multiple people barking out orders. And duty are delegated. We have someone doing the chest compressions and someone doing the respiratory evaluation and someone pushing medicines. But we also have someone doing recording. What is going on and when? And any bystanders are sidelined. They're not excluded, but they're not part of the process. And you don't panic. I mean, there's an old axiom that you take your pulse first. And so one of the things with this, I've noticed a lot of the leaders were maybe working 20 hours a day, 7 days a week, but they had to take time out. They had to be told, and we had to tell our other people that are co-leading, hey, it's time for you to take a rest, unplug, and get away. Okay, then the ABCs, instead of airway, breathing, and circulation, those are asking background and clarity. Like the 3 parts that ADCAR goes away, we need to know what is needed, and we need to know why it is needed. We need to deliver that message, and then clearly and succinctly how to do it. Those are the 3 questions that replace ADCAR when you're talking about situational change management. And then systematic and automatic recheck. We don't just start a code and then never stop. We actually check the pulses. We check again at systematic times. We check back and determine how the patient is doing to escalate or de-escalate the processes that we're doing. And then lastly, the big and most important part of a code blue in a clinic that's running those successfully is that you have to look at a debrief. What went well? What didn't go so well? And debrief on that. And then also the personal experiences. Sometimes a debrief is a code, is someone that was really affected by what happened. So that takes me on to the next part of what I feel that we're doing really, really well, and I think is something to share, is that the tools to do human change management prospectively are the same ones we use retrospectively, meaning we have an awareness. We have people, we need them to be aware of the stress that they're going through. And we have to have them understand what the outcomes of those stresses are. They might feel just frustrated, or they might feel tired, but really that might be the stress that they need to be addressing. And then we need to deliver knowledge on where to go to get the support and have stuff there for them. You have to have the ability for them to alter their stressors that they're having. And then reinforcement, meaning we need to measure what's going on with our staff and a goal and make goals to so we remeasure and redesign that. So for instance, the HELP, which is healing the emotional lives of peers, is a program that was just stood up here the last couple of months. Next week, I'm actually going through my HELP training to become one of those peers to help others. And then we have the COVID-19 well-being page that people can turn to if they need information about finances that are affected because of COVID-19, which can be a big stressor. And then in HICS, or you might call it HICS, the Health Incident Command Center in your organizations, those are long hours, people working long hours. So we've set up recreational areas, places that people can step away and decompress and meditate, get food and nutrition and those sorts of things. And then a Let's Talk warm line that's always available and staffed so that people can call if they need to vent or if they need to speak beyond those tools that are available typically in an EAP. We need to go beyond that in the times of crisis. And so this is examples of what Mayo Clinic have done. Okay. Now I showed you a couple of graphs that I talked about that discussed, how we had changed, gone through the specific change. But I wanted to make sure I don't just talk flowery and give takeaway, maybe some concrete lessons and maybe discussion points for after I stop here in a couple of minutes. But we need to alternate change management. And when we do that, that's not the same as just not doing change management. The alternate change management is flatter, it's more nimble, but it is much more requiring of numerous wrap back processes. And every one of the things that I talked about has a technical wrap back. Like I went into specifics about the Ask Mayo expert that we're now going back and doing usability studies on what we put out there. But also I spent time obviously talking about the personnel wrap back processes as well. And reprioritization. In our Clarity queue, which keeps track of all the major projects, we had 400 to 600 projects, and we whittled that down to 20 projects. That was a huge change. But now we have that delicate matter of reprioritization, and those meetings went on as soon as we de-escalated. Those meetings started on, okay, what are we going to do to re-escalate? Because remember, those are 400 to 600 projects that we endorsed. Those are 400 to 600 projects that we thought were winners. Their reasons were we needed to be there, but then we had to almost choose winners and losers from that list of winners, and now we have to reprioritize that. And our leaders are taking that seriously, and I'm excited to see that. And then this whole reactivation, I talked about furloughs and that sort of thing. Do we need to staff to our workload, or do we need to drive our workload to our staffing? There's different ways of getting to that. But the point is it should be data driven. So I'll kind of point out those two graphs. These are the badging. These are the people that are working offsite, okay, or on furlough and those sorts of things that had decreased significantly. And then this is the patients that come through our doors, okay, that same time period. So I'll go backwards and look at that red line to the right. And that's the sort of data-driven decisions that said, the finances are coming back later, but our leaders are already realizing that we're closing the gap quickly because we've worked hard with our community to create trust, and we worked hard to get our messages out there, and we've worked hard to figure out the safest way to do all this. And so quickly the patients are coming back, but we have to relieve that staffing gap, and they've done that. And so we're backing off on our furloughs real quickly and reorganizing and restructuring our workloads to meet that staffing need. And then lastly, the thing that was ubiquitous from all of my interviews was this gratitude and grace, this sense, like Dr. Gray had said, he went out and often rounded because he wanted to go out and comfort, and he wanted to console, and he wanted to tell people he's there for them. But he found every one of those times he would go out, he would come back saying, actually, people were saying they're there for me. They were asking how I am doing and that sort of thing. They were assuming good intent. And so despite all these changes, the needs of the patient still come first. Okay, that's a shared purpose and a core principle. And what I wanted to reflect and leave you with regarding that is that, in fact, the chaos that we went through made our core principle crystal clear. We say it over and over and over again throughout the 15 years I've been at Mayo Clinic, and sometimes previously it just felt maybe not as important to say it, or perhaps even a little bit scripted. But because we'd said it and said it and said it, it's become a part of, so it becomes our core principle, so that in times of stress, it becomes what we focus collectively as a group. And I'll leave you with one last comment that Dr. Gray said that I thought was very insightful, is everyone says things are different. It's like we're plumbers doing electric work, you'd think. Our change is huge, no doubt, but I think it's more like we're bakers. Our bakery has a good reputation for great treats, and those are coming from wholesome, fresh, organic, and rich ingredients. And this doesn't seem to me to be fish out of the water type of change. We have a whole new recipe today, but we are still cooking with all the same wholesome, fresh, and organic ingredients. And when he said that, it really resonated. that's what I wanted to deliver. I wanted to get 45 minutes of your time to kind of describe what Mayo Clinic went through change management, and hopefully you've thought of some questions or maybe some comments that we can lead the group through on discussion. Rebecca, I'm open for the chat now.
Great, thank you. We do have one quick comment on here. Stephen Campbell is on the line and said thank you for the shout out. So if you do have a question, please type that into the question section of GoToWebinar, and we'll get that to Dr. Gordon here. In the meanwhile, while we're looking to collect questions, Dr. Gordon, you know, we're still in the midst of this pandemic. As we're moving forward, do you feel that the rate of change is still adjusting your approach as you're going forward through this? Or do you feel like you're settling into a little bit more of a new normal?
Well, we certainly won't return to normal. I think it's pretty well understood by those people that I've talked with, and probably you're feeling it in your organizations, for those that are listening, that we're going to come out of this different than when we went in. And that, I don't mean to say that again and again and again, but this new normal that you talk about is that, yeah, I do feel that there was a while there where what was disconcerting for many of us was that those decisions were feeling like gambles, because we as decision makers, we need information to make the decisions. And frankly, the information just wasn't there, or the information was maybe contradicting, and it almost felt like a guess. And those are when change management was also, decisions were actually almost feeling like a gamble. And I think at this point, where things aren't gone, change is still here, and it's still readily around every corner, but it feels like perhaps the gamble is decreased. And for that, I think I'm thankful that, again, we've amped up our communication streams, we've amped up our knowledge base, and amped up our way that we express that knowledge, so that everyone is just more aware. And I can't say that we were caught unaware about COVID back in February and March, but I don't think most of us have lived in healthcare long enough to know the significance that it's going to be changing our schools, and it's going to be changing our ability to make house payments, and it's going to be changing our churches. And in a way, healthcare is just a member of this huge community of industries, and that's where I think things were quite unnerving. So I think, yes, I do feel it's changing back to somewhere between the ADCAR and the more slimmed down situational change management, but it's still, we still have to be ready for a sudden change, as you hear about other states suddenly having more outcomes of COVID breakouts. And is there going to be a phase 2 on this? And that's yet to be seen on how each organization, region, state is going to be dealing with that.
Great, thank you. We have a couple of questions on telehealth. How are the docs at Mayo embracing telehealth as you reopen, assuming a fee-for-service environment? And do you think telehealth is here to stay?
Well, I think telehealth is here to stay. And we have goals for that. I mean, we have goals for ourselves about what level of telehealth is going to play. Now, I didn't talk about it much, but it's not something that's a secret, but Mayo has a 2030 plan, a plan of how do we get from here to there. And in it, what was maybe a silver lining on all this is that this clarity of purpose and this sudden excessive need for use of telehealth and just to keep us available for our patients really accomplished what I thought was going to take 3 to 5 years, and it took 3 to 5 days. And so, but there is, I think, all around us, as we open up our doors for in-person care, there's going to be this slow decrease in the utilization of telehealth. And I think that's going to be the challenge for us, is to anticipate that it slides back, but make sure that it's available for patients. And a lot of that communication that I talked about was inviting and encouraging patients to continue to utilize telehealth services for those things that are appropriate.
Thank you. In your opinion, what is the best method for choosing winning projects from a list of winners?
Well, you know, this was one of those things that happened at such a high pay grade. I'm not sure I could. I mean, at the size and scope of Mayo Clinic, these are huge mega programs. These aren't small programs. But again, it's just a matter of getting the stakeholders around the table. It wasn't as hard as you think it would have been, because there was just no question that the novel coronavirus, and its first name is novel, which is unknown, became all-consuming. And if you weren't directly connected with a project or a program to novel coronavirus, you had to step aside. And I don't think there was any questioning from our staff and our leaders about how important it was that we focus on this and get it right. And because it mattered for our organization, but more so it mattered for our patients' health and the viability of community wellness. So I think it's just a matter of getting all stakeholders involved, and then, like I said, when you have to do such dramatic cuts, making sure it's on that quick, like the quick description of the why is that we're going to COVID-19 as an isolated focus, and it just wasn't questioned, and it was consistent at every level, and so that made those changes occur. Now, as we go back and start to open up the door, then it's becoming, like I said, maybe a little bit more hard strategy. But that prioritization and reprioritization is occurring multiple times a week. It's not something we do on a monthly basis, or we did once and we come back to it when we get to it. No, it's happening weekly. And Dr. Gray and Dr. Hebo made it real clear to me that this prioritization and reprioritization by the practice of the needs of the practice and the needs of the healthcare consumer, that's something that's in constant digestion.
What strategies did you use to organize the Zoom classes for your staff in your region?
Oh, that's a great question. I mean, basically, what I emphasized there was change champions, okay? It was fairly organic because we have a fantastic group called the Center for Connected Care, and they are driving things at an institutional level. This is 30,000 foot in the air, 30,000 foot in the air movement of an enterprise, okay? But again, an enterprise is a collection of individuals, and if you have some individual leaders, so a department chair or a regional champion or someone that is one handshake away from the end user, and you can get them to align with a curriculum. So basically, we developed a curriculum between 3 to 4 providers. Those 3 to 4 providers figured out the tool utilizing Center for Connected Care's expertise, and then drove exactly what you need to know in 2 sessions. So teaching Zoom over Zoom was seeming ridiculous. We're going to teach you how to use Zoom while you're on Zoom. But in a way, it was masterful, because if you can't learn about Zoom using Zoom, then how in the world are you supposed to do healthcare over Zoom? I think many organizations actually maybe contracted out their telehealth. In Mayo Clinic, we didn't do that. We own it whole kit and caboodle. Now, certainly the tool Zoom isn't something of Mayo Clinic's, but Mayo Clinic's iteration and utilization of that tool was an entirely homegrown, self-owned, I would say hopefully best in class tool of how we did that. But I would, again, if you're out there and you have something, you need to identify change champions, people that have skin in the game, people that have good connections, are respected inside of their group, inside of the organization. You need to give them the content, but also the curriculum, but also let them have a say, let them change it and use it accordingly. So we made 2 classes, the basic class, and then we invited people to come back for the end user class. We have, like, I don't know, 700 providers or something like that could have been offered it, and 500 showed up for it. So I thought that was speaks volumes of how successful that process was.
Can you speak more to the significant downstream IT dependencies? Assuming that Mayo is already on a cloud platform and can optimize their AI strategies.
Well, this is probably where I'm a people's informaticist, and this is where I'll defer that question. You could ask it again, maybe with different words. I understood the question, but I just don't think I have the expertise to answering it knowingly. And so those IT people that are maybe on the line and listening probably should be answering that question. So I'll defer that one.
Sounds good. Can you share information about the contributions of various organizational groups towards helping you shepherd change with COVID-19?
Oh, absolutely. This was, again, I was more of a journalist in this discussion than an actual contributor of this discussion. In a highly matrix organization that needs to run efficiently, there was contributing organizations that I think what I saw was that there was individuals that stood up, but those individuals were often in small teams where they could utilize synergy in messaging and synergy in activities. And let's say, for instance, even Michelle, who was in MENIC, the Management, Engineering, and Consulting Group, which are, think of it as internal consultants that make sure we kind of do everything right. That group, Michelle herself, Michelle Hoover, she had a single person that was her backup, because it was clear that this was an ongoing game. This was exhausting, and we can't exhaust the people doing the work. And so nearly everyone that I talked with had someone that they turned to that they could hand off to get rest and that sort of thing. But again, the strategies were were very cooperative, very collaborative. At times, I mean, I have to tell you, there was this last month and a half was very challenging. I do not want to suggest it was all rainbows and rose petals for me. There were some really, really personally challenging and professionally challenging events that occurred. And Mike Ryan did say, I'm 35 years I've been in IT at Mayo Clinic, and he's a gifted thought maker. He said there was one day that was the worst day of his 35 years, and it was with this COVID crisis, and it was telling his staff about the furloughs and the cutting that he had to do. And so this was certainly hard, but again, as long as we remembered the people and those sorts of things, and then, like I said, almost everyone went back to, we knew the purpose, and we knew that there was amazing amount of grace extended to us from our end users and from our staff. There wasn't a huge amount of pushback from any of the bad decisions that we had to. The only, most of the negativity came from internal, from ourselves, self-doubt, uncertainty, and just plain fatigue. And I'm hopeful that other organizations had that same experience, that this was a crisis that was in our society, and don't, for the most part, don't bite the hand that feeds you, sort of thing.
Perfect, thank you. We have 3 minutes left here, so we'll have time for one more question. What are some treatments that Mayo is pioneering?
No, that's great to hear about. Well, I know that University of Minnesota was involved in a study looking into the falls out of my head right now, of medications that we can use, and I don't know they extended that to Mayo Clinic patients, and so we saw that happening. And I also know that the antiviral agents are being used, as well as the steroid agents are being used, and those studies, if you're interested in participating in those studies or having patients participate in those studies, if you go to just plain Google and type in COVID-19 Mayo Clinic Ask Mayo Expert, or just COVID-19 Ask Mayo Expert, it's going to take you to that COVID-19 page. And I think the third tab over, or something like that, is going to have available trials. And you can look at all the different trials. The one that I've been personally involved with is, just because I've been extending my patients and having some conversations with Dr. Joyner about, is that passive immunity program, where patients are giving their going in for giving of plasma and extracting off the antibodies to see if that passive immunity can help with people that are going through the ARDS type of reactions that is taking the lives of so many. But again, I would point you, if you're interested in learning more about the trials that are ongoing for treatments, it's right through that. It's through that Ask Mayo Expert page, and it has a tab on it about available trials that are going on right now on the 3 different campuses: the Midwest campus, the Florida, and the Arizona campus.
Thank you. Thank you, Dr. Gordon, so much for your time today and presenting to our community. We really appreciate your insights and your information. Thank you.
Well, thank you. And it was, like I said, it was great to present to you, but it was also great to have that challenge to incite me to start investigating, what are we doing and how are we doing it and how is it affecting us and where are we going? It was very much a learning opportunity for me. So thanks again.
Thank you.